I'm Tahir Latif. I am Associate Professor of Hematology Oncology at the University of Cincinnati.
Hi, so can you just give me a little bit of an overview about the study you were involved in on gender-specific mortality in diffuse large B-cell patients receiving R-CHOP?
Yeah, what we did was we looked at our own experience in the University of Cincinnati about patients with diffuse large B-cell lymphoma. We know that age is an important factor in terms of how the patient fare or how they do, but we were surprised to see the gender or the sex was also a very important factor in prediction of their mortality. We noticed that the study duration mortality for females in that is about 16% in our group of 122 patients, while it was about 26% for the male patients or male counterparts. We think that this is because maybe we're not able to provide them the rituximab because the way we use rituximab is through the body surface area, and male may not be getting enough of it as opposed to females, which are usually have a shorter habitat. But that's something of interest to a lot of people, and a lot of work is going on trying to figure it out why there is that disparity in their mortality.
So how does knowing that there is this disparity impact treatment?
Well, eventually you will want to find a reason for that and try to fix it so that there will be no disparity. We will know both genders are doing exactly the same. If it is they metabolize the drug much quicker, or if it is that we need a higher doses in the male, we want to know those kind of things so we can make the difference.
And just what are some of the challenges in general with treatment of large B-cell lymphoma?
Well, to me, diffuse large B-cell lymphoma, although classified as one disease, is really not a one disease. We have lumped a lot of different groups of patients into one. So I think recognizing those patients, which subgroup they belong to, and treat them accordingly is, I think, the biggest challenge when it comes to diffuse large B-cell lymphoma, meaning one stick is not enough for all the patients here. There are some patients who had good risk factors and they will do much better. There your focus is to try to avoid the toxicity of the treatment so they don't have to deal with it. On the other hand, there are some patients who will not do well, and there are some ways of predicting that, both traditionally and more recently genetic and molecularly, to kind of figure those things out. And it's important to give them appropriate therapy, to intensify those therapies at the get-go so they don't have to deal with the relapse. Treating relapse in diffuse large B-cell lymphoma is probably the toughest proposition. We have best chance at our initial treatment to, in fact, cure those patients.
Are there any novel therapies on the horizon to treat relapse patients?
Absolutely. I think it's a very exciting time for this particular disease. We understanding the molecular mechanisms of how cancer develop, and now we have developed several new targeted therapies that will become part of our traditional chemotherapy. CHOP was the standard of care for this disease for years and years, for decades, and in the last 3 to 5 years is when we're actually seeing more breakthroughs in this disease. And I think next 3 to 5 years we will learn how best to use those new targeted therapies and where to incorporate it in to make a difference in a patient's life.
Do you think CHOP will always be part of the treatment?
For diffuse large B-cell lymphoma, yes, because you do need to cut down the large volume of disease when most of these patients present, but I think the role of the CHOP will become much more limited, and I think we will learn just to use the right amount, not going on 6 or 8 cycles and not going on months of therapy, but maybe do a couple of months of therapy to cut down the disease volume, but then maintained it with new novel targeted therapies.
And that would cut down the toxicities?
Absolutely. That's the whole hope.
With all these new novel targeted therapies becoming available, is there challenges in figuring out the sequence of what should be first line, what should be relapse?
It's little early for that because we just got them. So we're using them in patients who are relapsing or who really need them. But then I think with time, I'm sure we will understand exactly how to sequence them or where to use them. This is going to take some time, but we will figure this out.
Are there any, in this space at ASCO, is there any things that you were excited about the results of while you were there?
Well, the theme of the ASCO is immunotherapy. This is what's almost in every area of oncology we've been hearing, and then in hematology too. I think the highest response rate we looked at is in Hodgkin's lymphoma with these immunotherapies. So quite excited to see how those will work when we unleash the immune system.
That's all I have. Unless there's anything else that you want to say.
Thank you.
All right, great, thank you.
Okay.